Should I start now or wait a bit?
We have everyone from the last one as Husna joins, so start now.
Okay. So I'll just present. Can you guys see my screen?
Yeah.
Yeah. Okay, perfect. So I'll just be going through Pharm, so drugs and neurotransmission, looking at adrenergic and cholinergic nerves, and a bit about envenoming, and then a bit about anti-cancer drugs. So there's this yield system, and we'll get started. So this topic is like quite high yield. Oh, and sorry, I forgot to introduce myself. I'm also a second year. I'm just like guest lecturing for today. So I'll be covering like the Pharm for this week. And just this first lecture, as well as the associated workshop with it, is like, I thought it was quite high yield. Like it came up on quite a lot of questions in our practice exam and then our exam as well. So if you have any questions, feel free to just type in the chat, and I'll try and address them. And yeah, just hopefully you can get like an understanding of this. And it's also important for SEM 2 as well as year 2 as we go into looking more at the autonomic nerves and stuff. Okay, so with the nervous system, hopefully you know by now that the central nervous system is the brain and the spinal cord. And then we're looking more at the peripheral nervous system in terms of its divisions, of somatic and autonomic nerves. So somatic nerves, remember, are those that are voluntary, and they usually are controlling your skeletal muscle. And then you also have your autonomic nerves, which are involuntary, controlling your various body functions. And then that splits up into sympathetic and parasympathetic. So we'll be looking at today adrenergic nerves, which are generally the nerves that are in the sympathetic nervous system. So that's why I've got an arrow here. We'll also be looking at the cholinergic nerves. And these cholinergic nerves have both somatic cholinergic nerves as well as autonomic cholinergic nerves. So the somatic ones are obviously for the somatic nervous system, and then the autonomic ones are for the parasympathetic nervous system. All right. And I put in bold the somatic cholinergic nerves because we'll be looking at that in a bit more detail, because you've done some physiology on Pharm, etc. So that's going to be our main focus. And sorry, you've done some physiology on your muscles and skeletal muscles. So that's why we'll be looking at the Pharm of those skeletal muscles and the nerves innervating those. Okay. Also, just very quickly, just remembering that the point at which you have the neuron, so the axon terminal of a neuron, joining on or communicating with another another cell, so another neuron, is going to be the synapse. It's also known as a ganglion as well. So we can call this the presynaptic neuron, and then we can call this the postsynaptic neuron, or we can call it the preganglionic neuron and the postganglionic neuron. All right. So this is a very quick summary of the types of nerves that we have. So we've got the somatic nerves, and what you'll see is that there is no ganglion for the somatic nerves. All right, they go straight away towards the skeletal muscle, and they don't synapse halfway through, and then they release acetylcholine, ACH, as the neurotransmitter, and that acts on skeletal muscle, and those are the N receptors on the skeletal muscle, which are the nicotinic receptors. Okay, so they act on the nicotinic receptors in skeletal muscle. So these are your somatic cholinergic nerves. All right, so the neurotransmitters, basically, whenever it releases acetylcholine, it's considered at the end, it's considered a cholinergic nerve. That's why you have the somatic nerve at the top being cholinergic, as well as the parasympathetic nerve. As you can see at the very end, it also releases acetylcholine. So it's also considered cholinergic. All right. And then you have sympathetic nerves, which have noradrenaline or adrenaline being released at the endpoints. Okay. And those are considered your adrenergic nerves. So with sympathetic and parasympathetic, you also realize that because both of these are autonomic nerves, you'll see that they have both a preganglionic nerve as well as a postganglionic nerve. And in between there is the synapse. So we can also call this presynaptic and postsynaptic. Okay. And this will become more important as we go into semester 2, but it's also good to understand for now. Okay. Don't worry too much about the adrenal medulla for now. because that's more covered in semester 2. All right. So we'll first start off by briefly mentioning adrenergic nerves. These are less important in semester 1 compared to cholinergic nerves, but it's still good to have like a basic understanding of this because you'll be doing a lot more on it in semester 2. So with your adrenergic nerves, you've got these nerves releasing adrenergic transmitters. So they're namely going to be noradrenaline and adrenaline, and they are used in the sympathetic nervous system. Of course, there are some exceptions, but we won't worry about them for semester 1. And hence they innervate the gut, the lungs, the heart, and blood vessels as well. And remember, sympathetic is fright, flight, and fight. So you've got a dilation of the pupil so that you can let in more light. You've got a dilation of bronchial smooth muscle so that you can breathe more. So bronchial just means lungs. So you've got the dilating your lungs so that you can take in more oxygen. You've got an increase in heart rate, and you've also got vasoconstriction on the skin because you don't want too much blood being there. Instead, you want the blood being in your skeletal muscles. So you've got vasodilation, meaning that your vessels are enlarged towards your skeletal muscle. So you have more blood going towards your skeletal muscle so that they can work harder, so that you can run or you can dash away. And also inhibition of the GIT because you don't really want to digest. That's not your main focus. You want to get away from the danger. All right. So those are the functions of the sympathetic nervous system. And remember that all of these functions are controlled by adrenergic nerves, which release usually noradrenaline, also known as norepinephrine in American textbooks. And they will be acting on alpha and beta adrenergic receptors in the target tissue. All right, so these are your adrenergic nerves. So there's a bit more detail about this. So first of all, the synthesis of the neurotransmitter is synthesized from tyrosine, and then you end up having also a negative feedback system, which means that this enzyme is inhibited once you have a lot of noradrenaline or adrenaline. You also have for the response of the receptor. So we talked about this before. You have your flight and fight response, and you have two main receptors. So the noradrenaline, which gets released from your adrenergic nerve, is mainly going to be acting on your alpha or beta receptors in your target tissue. So in the gut, you would have alpha and beta receptors, and the result of noradrenaline acting on these receptors will be an inhibition of the GIT because you don't want to have digestion occurring while you're running, okay? In the heart, it's going to be mainly beta receptors, and they will be controlling your rate and force of your heart contraction. So they'll be increasing that so that you can have your more blood pumped around your system, okay? For your lungs, it's going to be also mainly beta receptors, and it's going to be increasing bronchodilation so that you can let more air in. And then for blood vessels, you might have vasoconstriction in some areas, or you can have vasodilation in other areas as well. So just remember for this slide, it's more of a big picture understanding. It's going to be mentioned more in semester 2. So you'll be looking a lot more at these autonomic nerves in semester 2. So don't stress too much about which one's alpha, which one's beta. Just more focus on the effects of the neurotransmitter on the sympathetic nervous system. So if I activate these adrenergic nerves for a sympathetic response, I'm going to have increased blood flowing around and increased oxygen into the lungs. Okay, that's like fight and flight response. All right, and then obviously there's also going to be the release of the receptors from the neuron, and that's going to be triggered by amphetamine, but you don't really need to know too much about that. Also, the removal of the neurotransmitter noradrenaline or adrenaline is going to be done via uptake. So that's going to be via either uptake terminals back into the nerve or broken down by the enzymes in that synapse area. So here's a diagram. You can see that we've got the tyrosine that is going to be acted on by enzymes to stimulate noradrenaline, and then you've got noradrenaline. Basically, once you have that action potential coming in, noradrenaline will be in the vesicles, and then they'll be ready to be exocytosed outside into the synapse. And then, so it's exocytosed into the synapse, and then it acts on either alpha adrenoceptors or beta regenoceptors, depending on what the postsynaptic cell is. And then afterwards, once that's done, you can have, for example, either uptake by the postsynaptic cell, or you can have reuptake into the original cell, or you can have the noradrenaline broken down by enzymes in this space as well. So just a big picture understanding for adrenergic nerves. Then we get to cholinergic nerves. Remember that cholinergic nerves are the ones that will release acetylcholine at the endpoint. So we're looking at the somatic nerves that release acetylcholine that acts on nicotinic receptors, and then also parasympathetic ones that act on muscarinic receptors at the end, okay? Also just note that the sympathetic nervous system, even though it's associated with adrenergic nerves, you also have at the start of your sympathetic nervous system, you'll have a short preganglionic fiber that will actually release acetylcholine acting on a nicotinic receptor, but that's not really that important right now, okay? So focus more on these two. So cholinergic nerves can innervate your somatic, so as in your skeletal muscle, and that will be nicotinic receptors. So remember that somatic goes with nicotinic, okay? And then your autonomic cholinergic nerves, which innervate your parasympathetic nervous system, will be muscarinic receptors. So that's why we have the M there, okay? So it will innervate the heart, the GIT, as well as the blood vessels. Okay, so just a bit about cholinergic nerves. So this is talking about both of these, okay? So that's parasympathetic cholinergic as well as somatic cholinergic. So we have the synthesis of the neurotransmitter is through choline, and then it's acted on by an enzyme, and it's a one-step pathway. You also have your response. So that's going to be acting on either muscarinic receptors or nicotinic receptors, okay, depending on which nervous system we're talking about. And for the autonomic effects, you're going to see that there's going to be an increased gut motility. So it's going to increase the gut contraction because we're currently in the parasympathetic. So that means that we're resting and digesting. That's the main focus. So we're really relaxed and we're trying to rest and digest. Then with your heart, for the autonomic control, you're going to see that there's going to be a decreased contraction in the heart because you're not going to be wanting blood pumping around the body too fast. For blood vessels, there usually will be some sort of vasodilation. However, it's going to be indirectly. It's not really going to be innervated by muscarinic receptors. So you don't have to worry about that too much until semester 2. And then more importantly, your skeletal muscle, it's going to be innervated by somatic cholinergic nerves. So that's not autonomic, that's somatic cholinergic nerves. And those will be nicotinic receptors, and they will be basically facilitating the contraction of the skeletal muscle. All right, so this response phase for cholinergic nerves is pretty important. Just make sure that you remember this process because it will be tested. With your cholinergic nerves, you're going to have electrical stimulus arrives. Basically, your action potential will arrive at your nerve terminal, and then that's going to cause an influx of calcium ions. So you can see that there's calcium ions coming into the cell, okay? And that's going to trigger your vesicles, which have acetylcholine in them, okay? They will be exocytosed. So you can see the vesicles docking at the membrane, and then they're going to be exocytosing your acetylcholine, all right? So then what happens is that your acetylcholine will bind to motor end plate receptors. So motor just means like your movement, okay? So it's going to be binding to receptors that face the nerve terminal on your skeletal muscle, for example, if we're talking about somatic, okay? So it's going to be binding to your receptors on your skeletal muscle. And then what's going to happen is that then that's going to trigger a whole bunch of events that will allow for skeletal muscle contraction. So we know that it's going to bind to your nicotinic receptor on here, and then you'll have sodium ions flowing in, and then all of the rest, which is more covered in physiology, okay, because depolarization, etc. All right. Just to note that with the removal of your acetylcholine, because it's been exocytosed, it's acted on the receptor, then what happens after that? Once acetylcholine has already done what it needs to do, then it's going to be usually broken down via enzymes. Okay, so we call these acetylcholinesterases or just cholinesterases. Okay, and they are there's lots of those enzymes in the axon terminal so that they can break down the acetylcholine really quickly. The reason why you need to have this really fast removal or breakdown of acetylcholine is because if it stays in the nerve terminal for too long, if it stays in the synapse for too long, it's going to repeatedly trigger off those receptors, okay, those nicotinic receptors on your skeletal muscle. And if you repeatedly trigger off those nicotinic receptors on your skeletal muscle, it can actually cause what's called a depolarization block, which means that you've overstimulated those nicotinic receptors too much that they stop working for a bit. Okay, so then that's going to cause like muscle paralysis, etc. if you have those nicotinic receptors stopping to work. So that's why you need to make sure that the acetylcholine is broken down really quickly, because otherwise it's going to cause a depolarization block. All right. Then for neuromuscular blocking drugs. So these are the drugs that you'll be learning about which act on somatic cholinergic nerves. Okay, so remember it's somatic cholinergic nerves, somatic S for somatic, and then also S for skeletal muscle. All right, so it's going to be innervating your skeletal muscle. I've screenshotted from the original big diagram, this neuron, like sort of neuron peak diagram, so that you can see that you've got the somatic releasing the acetylcholine, which is acting on nicotinic receptors on your skeletal muscle. We're not really going to be dealing with the sympathetic and parasympathetic drugs too much, because that will be covered more in semester 2. So in semester 1, we're really just dealing with somatic, so your the drugs that will act on skeletal muscle and that nicotinic receptor. Okay, so we call this neuromuscular junction. So this place where you've got acetylcholine binding to nicotinic receptors, they're called neuromuscular junctions, or NMJs. Okay, and that's the junction between your somatic nerve and your skeletal muscle. All right, just recall that your skeletal muscle is innervated by somatic nerves, which do not have a ganglion, so they do not synapse in the middle. Okay, and they are cholinergic, meaning that they release acetylcholine. So acetylcholine binds to nicotinic receptors. So this is all really core knowledge. All right, so we're going to start off by looking at some of the drugs that can block this neuromuscular junction. So since they're blocking drugs, they're going to be stopping the neuromuscular junction from working properly. Okay, and sometimes we use them and they've got various purposes. Okay, so we're first going to look at a non-depolarizing blocker. So that's the first type of neuromuscular blocking drugs. It's a non-depolarizing blocker. Okay, and the drugs that commonly are this class are going to be rocuronium and tubercularine. But that's the second one isn't really in our core drug list, so we don't have to worry about that too much. It's mostly looking at rocuronium. So we've got rocuronium being a competitive antagonist of your nicotinic receptors. Okay, so what that means is that, remember we learned about antagonists like last week. So it's going to be basically, it's going to be acting on, it's going to be binding to your nicotinic receptor, and it's going to be standing there and not letting acetylcholine bind to that receptor. Okay, so it's going to be antagonizing the nicotinic receptor. All right. Yeah, so we can also remember it as sitting like a rock, because it's kind of got like the ROC start of the word on the N receptor as antagonists. All right, so non-depolarizing blockers will not cross the blood-brain barrier, and also they can be overcome by increasing the concentration of ACH. So what that means is if I increase the concentration of ACH, then it's just going to find more N receptors, okay? And that way it can kind of overcome the effect on the drug, because some of the drugs will be sitting on some of the receptors, but then if I increase the ACH, it's just the ACH is just going to find more receptors at other places on your skeletal muscle. So yeah, okay. Then we have your depolarizing drugs, and these depolarizing drugs, are still also going to be neuromuscular junction blocking drugs, okay? However, they're going to act differently. So they are actually going to be agonists of your N receptors. So what that means is that they are going to attach to your N receptor and actually trigger the events that acetylcholine normally would trigger. So it's like going to be using the analogy that the lecturer talked about in the lecture, it's going to be the key will fit inside the lock and then it will actually open the lock, okay? So it will actually stimulate the N receptor, okay? But then the problem is that these drugs will actually be overstimulating the receptor. That's how they get their action done, okay? They will be overstimulating the receptor. And remember that with your nicotinic receptors, if you overstimulate the receptor, it will actually cause a depolarization block. We talked about that on the last two slides, okay? So actually cause a depolarization block because you've got your nicotinic receptor overstimulated. So you've inactivated that sodium channel on the motor end plate, okay? And that means that you will be inhibiting muscle contraction because your N receptors will stop working because it's been overstimulated. All right. And then the interesting thing is that the action of these depolarizing drugs are actually potentiated. So they're increased by an increase in ACH. Okay. So that's actually the opposite of non-depolarization blockers. Okay. Because non-depolarizing blockers will be overcome by increasing ACH, whereas depolarizing blockers will be potentiated by increasing ACH. All right. And the classic example of a depolarizing drug that you should know about is suxamethonium, and that has actually a very similar chemical structure as ACH. So the way I remember it is that because suxamethonium has a very similar chemical structure to ACH, what you'll see is that it will be acting on the nicotinic receptors, very similar to how ACH acts on it, but it will just be sitting on the receptor for longer, okay? Meaning that it will be overstimulating the receptor. Okay, so here's a summary of some of the drugs. So first of all, let's look at the last two rows. So you've got rocuronium and you've got suxamethonium. Those are your non-depolarizing and your depolarizing blockers, okay? And we've talked about how they work. So one is a reversible competitive antagonist, and then the other one is irreversible, and it's an agonist, and it causes overstimulation of your nicotinic receptors, and that prevents repolarization, okay? Also note how one is reversible. So rocuronium is reversible, whereas suxamethonium is irreversible, okay? So yeah, and then they also have some adverse effects, and they will be acting on your nicotinic receptors. Now let's look at these first three drugs, which are some new drugs that we haven't really talked about yet. So the first one is pyridostigmine, and that's going to be a reversible anticholinesterase. So if we break down anticholinesterase, so cholinesterase, remember, was the enzyme that is breaking down ACH. And this drug is an anticholinesterase, which means that it inhibits the drug that breaks down ACH. So if you've got a drug that is inhibiting the enzyme that breaks down ACH, then that means that there's going to be more ACH, right? Because you're inhibiting the breakdown of ACH, all right? So that means that there's going to be more ACH left in the nerve terminal, okay? And this can be used, for example, in a condition known as MG, okay, myasthenia gravis, okay? And this will be very useful for these patients, and we'll talk about that in the following slides, all right? But for now, just know that it's an anticholinesterase, which means that it will be blocking the enzyme that breaks down cholinesterase. Oh, sorry, the enzyme that breaks down ACH. You also have another one, which is pralidoxime, and that's going to be a cholinesterase reactivator. So that's actually going to be the opposite of pyridostigmine. Okay, and that basically means that you'll have the cholinesterases reactivated. Okay, and that means that you're going to have another increased breakdown of ACH because your cholinesterases, the enzymes that break down ACH, are back. Okay, so what does indication mean? Indication in the table means what it's used for. Okay, so indication means what it's used for. All right, so yeah, your pyrrolidoxime will be a cholinesterase reactivator, and that is useful when you have what is known as anticholinesterase poisoning. Okay, so let's define anticholinesterase poisoning. So anticholinesterase, remember, is the thing that inhibits the breakdown of ACH. All right, so sometimes you can actually have some pesticides or some poisonous compounds, some poisonous chemicals that will cause you to have anticholinesterase poisoning, which basically means that you've got the cholinesterases being inhibited. Okay, so in other words, you've got chemicals that mimic the function of pyridostigmine, okay, in your body, but you didn't actually want them to have like that effect. Okay, so you've been poisoned by drugs or by chemicals which have a similar effect to pyridostigmine. Okay, and because of this poisoning, you would therefore want to give the antidote, right? So then the natural way of doing that would be to give the drug that has the opposite effect of pyridostigmine, so that you can get rid of the effect of pyridostigmine-like compounds. Okay, so therefore we're going to give them pyrrolidoxime, okay, because that has the opposite effect of pyridostigmine, and you've been poisoned by something that was very similar to pyridostigmine. Okay, so that's where you would use pyrrolidoxime. All right, so it reactivates your cholinesterase, which breaks down ACH. All right, so just note how these two drugs, they're actually the opposites of each other, and therefore if you have poisoning due to this drug or possibly even overdose of this drug, then you would give the antidote, which would be the opposite of that drug. Okay, then we also have atropine, and atropine we'll talk more about as well in semester 2. But for now, what you need to know is that it is actually also a blocker of cholinergic nerves. So just like rocuronium or succinylcholine, it's also a cholinergic blocker. However, what it's going to be blocking is not your nicotinic receptors. Instead, it's going to be targeting your muscarinic receptors. So that means that it's going to be targeting the parasympathetic cholinergic nerves. All right. Remember how cholinergic, you can have somatic and you can have parasympathetic, right? So this one, atropine, is going to be targeting your parasympathetic cholinergic nerves. All right. And it's going to be a reversible competitive antagonist. So kind of similar to rocuronium, except it's going to be targeting your parasympathetic cholinergic nerves. All right. And this is often used when you want to basically stop activating the cholinergic, you want to stop activating the parasympathetic nervous system. So for example, if you want to dilate if you want someone to have their pupils dilated, so such as during an eye exam or something like that, you can give them atropine, because remember how parasympathetic acts the opposite way to sympathetic. So sympathetic dilates the pupil, parasympathetic will constrict the pupil. Okay, so we want to stop constricting the pupil so that it can be dilated. So you give them atropine because it stops the parasympathetic. Okay, so it stops the constriction of the pupil. All right, so that can be an indication of atropine. All right, this will be, as I said, it will be discussed more in future lectures in semester 2. Okay, so these are the 5 key drugs that you want to know about. They will actually ask about these drugs like on the exam, like they won't be so nice and they might not actually give you the class. So they might not say that rocuronium is a non-depolarizing blocker. Instead, they'll just say, what does rocuronium do? All right, so you need to know the names of these. Would atropine then stop the constriction of bronchi? So yeah, so parasympathetic nerves, parasympathetic will kind of be the opposite of sympathetic. So that does mean that you will have a degree of constriction of your bronchi, so your lungs. So it could be used for asthma, but the thing is that we usually don't actually give atropine for asthma, because the thing is that it does mean that you will be stopping the constriction of your lungs, because that is a parasympathetic effect. But then that also means that it will be stopping a lot of other things, such as the constriction of your pupil, such as the motility of your gut. Okay, so that's why we actually usually don't give atropine as our drug for asthma. All right. Instead, we actually look at it using the other from the other side, and we look at the sympathetic side. All right. And so we actually give them beta agonists because that would be more useful, because that's going to be very targeted to the lungs. Okay, because beta receptors are on the lungs. Okay, they've actually got beta 2 receptors on the lungs, so that's more targeted for the lungs. Hence, you'll have beta 2 agonists being given. That way, it's more selective. All right, because that way we can minimize the adverse effects. So that means that it's just going to be potentiating the sympathetic nervous system. Okay, giving beta adrenergic 2 agonists. Okay, so beta 2 agonists will be given for asthma. All right. Yeah, but you don't have to worry too much about that. That's literally like semester 1 of year 2. Okay, so don't stress too much. But yeah, good question. Yeah. All right. So yeah, so if we continue, then let's look a bit more at MG. So MG is an autoimmune disease that is targeting your nicotinic receptors. Okay. And what this means is that you'll have a reduction in the number of nicotinic receptors at your NMJ. So what will be happening is that your immune system will be somehow thinking that your nicotinic receptors are actually foreign, okay, when they're not, okay? And that means that they will be attaching antibodies produced by the immune system onto your nicotinic receptors. So as a result, maybe initially you had 1,000 nicotinic receptors, then now currently you might have half of them blocked by antibodies. Hence, you only have 500 nicotinic receptors left that still work, okay? So as a result, you're gonna have less nicotinic receptors activated because you only have 500 to work with now. And hence your muscle contraction has less force and is not sustained, and you're gonna have muscle weakening and muscle pain and yeah, bad endurance basically, all right, and heaps of other effects. So it's quite a serious disease. So remember, this is still your somatic, that's why I put this diagram in. It's still targeting your somatic nerves, okay, that release acetylcholine, that affect your nicotinic receptors, but now you're just going to have less nicotinic receptors to be activated, okay, because some of your immune system will be blocking some of them, all right, which is not normal, okay? You shouldn't be having your immune system coming in and blocking these, okay? So then if we think about the drugs that we can give for MG, you can give an anticholinesterase. Now, the reason why I would give an anticholinesterase, which if you remember is going to be pyridostigmine, okay, is because if we want to try and lengthen the time that ACH has in the nerve terminal, we would want to give an anticholinesterase so that it can slow the breakdown of ACH. Hence, it lasts longer in the NMJ, and hence that means that it has more time to interact with the nicotinic receptors that are there. Okay, that way you have a better chance of activating more nicotinic receptors. So just another question, why would atropine, which works on cholinergic nerves, affect the lungs if that's controlled by sympathetic nerves? So the interesting thing is that lungs and the heart, for example, all of these are controlled by both, innervated by both your sympathetic, so that's your adrenergic nerves, as well as your cholinergic nerves. Lungs is actually a bit different because your lungs, you actually don't have parasympathetic innervation of the lungs directly. It's more through like the adrenal medulla, but we won't really worry too much about that. But basically, atropine will most likely will affect the lungs because it's going to mean that you're going to have the blocking of your ACH. And yeah, so basically your lungs will be scattered with both adrenoceptors, so the beta and alpha adrenoceptors, or beta adrenoceptors, as well as your muscarinic receptors as well. So they will be on the lungs. So both of these will be on the lungs. That way you will have both sympathetic activation of lungs, which means that you've got the lungs dilated, okay, when you activate those beta adrenoceptors, or you could have parasympathetic, which basically means that you've got bronchoconstriction, which means that you've got the lungs becoming, basically you've got less oxygen coming in because you don't need so much oxygen when you're resting and digesting, okay? So hopefully that makes sense. So basically these autonomic organs often will have both parasympathetic as well as sympathetic innervation. Same with the GIT, okay? Same with the gastrointestinal tract. You'll have both the autonomic muscarinic receptors as well as sympathetic sympathetic adrenoceptors as well. Yeah. All right. Yeah, so that's why atropine. So you can either, so basically, if we think about like, now we're kind of going on a sidetrack, but if we think more about like how, yeah, if we think more about like how we can stop asthma, for example, we can either go from the parasympathetic route and block the parasympathetic route, so block the constriction, or we can try and help the sympathetic route. And we usually generally tend to try and help the sympathetic route, because that way it's more selective. Okay, just in this situation, it was more selective. So that's why we go that way. Okay, so that's why usually often there's going to be two pathways that you can go down. Same with dilation of your pupil. You can either go by trying to enhance the sympathetic route, or you can block the parasympathetic route. All right. Yeah. Okay. So yeah. So just going back to MG. So you can also use atropine. All right. So what atropine does is that it will block the muscarinic side effects of anticholinesterase, because anticholinesterase will mean that it will be potentiating the cholinergic nerves all throughout the body. So that includes potentiating the parasympathetic cholinergic nerves. And then we give atropine so that we can block those unwanted side effects. Okay. So anticholinesterases will often, what they'll do is they'll often cause the GIT to be more mobile, because you've got basically increased motility in the GIT, because you've got acetylcholine also being able to act longer in the GIT, okay, and stimulate muscarinic receptors. So then we give atropine so that we can block that muscarinic receptor. So we don't want that to be occurring, because we want to be targeting the skeletal muscles. We don't want to be targeting the autonomic side of the cholinergic nerves. We also give immunosuppressant drugs so that we can suppress the immune system, because that immune system is basically being too active. All right, so that's the first part, and now we're going to be looking very quickly at envenoming, which is relatively low yield, just a bit about like poisonous and venomous stuff, and then how you can treat like snake bite, etc. So if we have poisonous, that basically means that when you eat it or ingest it, you will die. Whereas venomous means that if something bites you, then they inject the venom into you and then you die. All right. Also, LD50 is the dose of the toxic agent or the venom that is required to kill 50% of the population. So if you have a really high LD value, then that means that it's going to be a not so good venom, like as in not so powerful venom, because you need a lot of the venom to kill 50%. Whereas if it's a very small LD50, then that means that it's only a little bit of the venom can kill like the population really quickly. So that means it's a very powerful venom. All right. So with your treatment for example, snake bite or something like that, we use pressure immobilization. This is like quite common sense. So you use like a splint, so that way it prevents the blood flow and the lymphatic flow, so that you can have it restricted to the part where you got bitten, so that you don't have it circulating all around your body. Okay. And you can give an antivenom where possible. Okay. All right. So then the types of toxins acting at the NMJ. So basically your venom that you've been bitten with could be any one of these three venoms. So it could be a presynaptic neurotoxin, and that acts slower and it acts on the nerve terminal and stops the release of the neurotransmitter, in this case, acetylcholine. All right. You could also have a postsynaptic neurotoxin, and that acts faster and it acts on the nicotinic receptors. So it basically blocks the nicotinic receptors. So very similar to a non-depolarizing blocker. Okay. And you also have myotoxin, which is very low yield, but it acts directly on the skeletal muscle. Okay. And it just breaks down the skeletal muscle. So these could be the types of toxins that you could have been bitten with. Okay. So this is just a picture of it. So you can see that presynaptic, basically what it means is that it will bind to these vesicles with your ACH, and it will stop the vesicles from being exocytosed. All right. Postsynaptic means that it will be acting on your nicotinic receptors. So you can see the stars there, and that means that it will be blocking the nicotinic receptors so that ACH can't bind to the nicotinic receptors. And myotoxin basically will be breaking down the skeletal muscle, which is here. All right. Okay. So feel free to keep typing questions about what we talked about in the chat. I can always jump back and answer some more questions about this, about what we talked about in terms of drugs and neurotransmission, but just keep in mind that's a really important topic, okay? So anti-cancer drugs, there's heaps of anti-cancer drugs. It's a bit of like just giving a whole list of anti-cancer drugs, the lecture. The good thing with anti-cancer drugs is I would say that usually you don't have to know the names of the drugs except for probably methotrexate. And you just need to know the classes of the drugs and what they do, so how they kind of work, okay? So don't worry too much about knowing the specific name of the drugs except for methotrexate, okay? Because the faculty will usually be a bit nicer with this one and just give you the class of the drug, okay? So you have classic anti-cancer drugs, and you also have novel anti-cancer drugs, which are the new types of anti-cancer drugs that have been developed recently, as well as other supportive therapies such as analgesics, so you can block the pain, as well as antidepressants, and also diet, which is related to HEP. Okay, so features of cancer cells. Because we're running out of time, I'm just going to skip this slide because you should have done that when you were looking at the biochem cancer lectures. So we're just going to look at some adverse effects of giving these anti-cancer drugs, and they will ask about this as well. So this is pretty important. So with your adverse effects of anti-cancer drugs, anti-cancer drugs usually target the rapidly dividing cell population. So that includes cancer cells that are rapidly dividing, as well as normal cells, which also rapidly divide. So as a result, you will have lower red blood cells, white blood cells, platelets that can lead to anemia. You will also have some problems with your skin cells because they are also rapidly dividing. As well as possibly some cells on the epithelium of your GIT. And then also your hair can fall out, as well as your sex cells can be vulnerable as well. Okay, so these are all some possible adverse effects because the drugs target rapidly dividing cells. And then you also have organ toxicity. So these anti-cancer drugs can be toxic to the heart, can be toxic to the nervous system. All right, can also definitely be toxic to the kidneys or the renal system because the renal system has to filter all of those drugs and eventually excrete them out, okay? And the urinary bladder, as well as some, and alkylating agents can have negative effects. Okay, so then managing these adverse effects, we usually tend to give, great. We usually tend to give anti-emetic drugs, because they will be, emetic basically means vomiting. So then anti-emetic means that you're reducing the vomiting. So you're stopping the vomiting because that can be an adverse effect. Okay. In particular relating to the GIT, see how there's vomiting here. And then also we can give colony stimulating factors so that we can stimulate the depressed white blood cell counts. Okay. So the first class of anti-cancer drugs are alkylating agents, and example is this drug. And it will basically form DNA cross-links and prevent DNA from unwinding in cell replication. So it will kind of join these two, for example, guanine bases. And then that means that when the cell wants to unravel, when the DNA wants to unravel for DNA replication, it will be affected, and hence it can't have that replication happening. Okay. In particular, it targets guanine bases, and it inserts onto the alkyl group of DNA. Hence, it's called alkylating agents. All right. And this causes stress when you want to unravel the DNA, so the DNA breaks and then apoptosis occurs. So affects rapidly dividing cells. So then you can imagine all of the side effects that we talked about on the previous slide. And it is cell cycle non-specific. In other words, it can affect actually the cell when it is at any stage of the cell cycle. This is also pretty important because sometimes they'll ask, at what stage of the cell cycle do alkylating agents work, or the other ones work? Okay, so wherever it's mentioned in the lecture, where they mention cell cycle, you need to probably take note of that. All right. Then we have cytotoxic antibiotic. So this is an antibiotic that is really, really quite toxic, okay? And hence, usually it's actually not commonly used for antibiotic treatment. So not usually used for killing bacteria. Instead, it's been adapted and being used for treating cancer, okay? So target cells with high turnover. All right, then you have antimetabolites. And this first type of antimetabolite is basically where it is substituted into the DNA synthesis pathway. Okay, so it can basically block DNA synthesis because it like substitute itself for some sort of enzyme. Okay, and then hence it stops this pathway. Okay, and as a result, it is S phase specific. Okay, in your cell cycle, and some side effects include your hair loss. Okay, and then your suppression of your myelin sheaths. And also literally affects the metabolism of cells, hence it's called anti-metabolites. So here's the important drug, the methotrexate. It is a subgroup. This is a subgroup of anti-metabolites, and it is specifically an anti-folate. Okay, so this is a specific type of anti-metabolite. So what it does is it inhibits an important enzyme, which is dihydrofolate reductase. Okay, and this is important in the process of generating folate or folic acid. All right, so it inhibits DNA replication, and it is S phase specific because that's where DNA is synthesized. So note the S to help you out in memorizing. So yeah, methotrexate is an anti-folate. Okay, and it is mainly used in the biosynthesis. This folate and then your folic acid and your dihydrofolate reductase mainly used in the biosynthesis of purines. That's your adenine and guanine bases. Okay, so that's the important one that you need to probably know about because it will come up again in semester 2. Okay, you've also got plant alkaloids. So these are derivatives from plants, and the first type is mitotic poisons, which will be cycle specific at your mitosis stage, and they will prevent mitotic spindles from being formed, as well as type B, which is your topoisomerase inhibition. And that's going to be interfering with the uncoiling or coiling up of your DNA in replication, because topoisomerase is used in that process, and it cuts the DNA so that it doesn't wrap. Okay, so these are plant derivatives. Yeah, methotrexate cannot be given to pregnant women. We actually got a question on our semester 2 exam, which asked about a drug, which drug cannot be given in pregnancy. Methotrexate was not on the list, but it was actually, because we were looking at cardio, and there were a whole bunch of cardio drugs. So yeah, sometimes it's actually pretty important to know about some of the specific side effects or some of the specific precautions for specific drugs, because they actually asked about that. So I thought that was a pretty mean question that they gave us last year. Okay, so hormones and hormone antagonists. These are used for reproductive cancers. So that's mainly looking at breast cancer and prostate cancer. Okay, so you can give tamoxifen, okay, which is going to be a estrogen receptor modulator. And yeah, so it can be agonist, antagonist, or basically it can basically mean that it will bind to your estrogen receptor, and that means that your estrogen or your estradiol, which is basically a derivative of estrogen, will not be able to bind to that receptor. You also have aromatase inhibitors, and an example is this drug, and it converts androgen into estrogen. All right. Yeah, so these drugs, again, you don't need to know the names specifically, but just know the classes of the drugs. Prostate drugs, so you can have anti-androgens. So androgens are the male, basically the male hormones, and then you can have anti-androgens so that you reduce the population of androgens in your body. Okay, and you also have gonadotropin RH. RH stands for releasing hormone analogs. Okay, so gonadotropins are the hormones that are secreted by your anterior pituitary gland, and it stimulates, for example, the production of androgens, which are the male hormones from your gonads. Okay, so then what that means is that if we inhibit if we basically inhibit your gonadotropins, then you have less androgens secreted from your gonads. All right, and then also glucocorticoids can be useful for blood cancers because, yeah, basically they can induce apoptosis in certain lymphoid cells. All right, now looking at novel agents. So the first type of novel agents are monoclonal antibodies, and these will end in the suffix mab, okay, so MAB, all right? And these are basically unique lab-produced antibodies that are made through a mouse, and they immunologically fight a cancer. Okay, so they're basically targeted at the cancer cells. Okay, there is a risk of immune reaction because they are taken from a mouse, and hence your body might think that they are actually foreign. Okay, so sometimes they don't work as well, but these are a really important basically research field, and there's been more and more monoclonal antibodies being discovered and created right now. You also have biological response modifiers, so you can have increasing the defense of your immune system through interferons, which are kind of like signaling cells in your immune system, as well as interleukin-2. And you also have intracellular signaling molecule inhibitors. Okay, so these will inhibit protein kinase, which you may have learned, you may have talked about a bit in your cancer workshop. All right, which is basically where it's an important enzyme that is used for the proliferation of your GI tumors. Okay, and as a result, what we can do is we can inhibit this enzyme so that there's less cell growth of your GI tumor. Okay, and this drug can also inhibit angiogenesis, possibly. Okay, and it ends in inib. Okay, all right. Then we move on and we have sensitizing agents, so it makes the cancer more recognizable by the immune system. However, it can only work for the cells on the outside, so on the periphery of the tumor, and yeah, it will induce an inflammatory response. Okay, so some treatment complications. These are also pretty important to know about for like some multiple choice questions. So first one is drug resistance because of spontaneous mutations of your cancer cells. So as a result, we can have ways to deal with that. So including a drug holiday, which basically means that there's a period when the patient stops being given anti-cancer drugs, and that way the body can recover from the toxicity of the drug. And during the break, the cancer cells will stop growing reflexively because of the previous anti-cancer treatment. Okay, and also the dying cells can kill cells around them, because when a cancer cell possibly like bursts, then it can actually also release toxic things to the neighboring cancer cells and also kill them on this drug holiday. So it basically gives some time for the body to breathe and do its own work. All right. There's also multiple cytotoxic drug therapy, basically, which means that you've got a bunch of these drugs that I talked about previously used at the same time. All right, then some other treatment complications include tumor cell sanctuaries, basically where you have the tumor growing in compartments where the drugs can't reach. Okay, and some solutions include obviously surgery or radiotherapy. You can also have dose exhaustion, which is where you've used the maximum dose of that anti-cancer drug, and any more of that drug would be toxic. Hence, you have to stop giving that drug. And then the solution to that would be to give another drug of a different class. Okay, that way because you don't want the drug to become toxic to the patient. Okay, and also surgery, radiotherapy, and other chemotherapy options are the solutions to that. And just a very quick question, if you guys want to put in the chat, what phase of the cell cycle does methotrexate affect? Yep, so it's going to be your S phase. All right, oh, sorry, I didn't have the answer there, but yeah, it will be the S phase, okay? Because it's going to be affecting that synthesis phase. All right, I think that's it for me. I went a bit over time, sorry about that. Any questions? I'll probably stay for another 5 minutes or so. That way, if you guys have any questions that are directed to me, I can kind of answer and jump in and reply to the chats. But otherwise, thanks everyone, and I might be back in semester 2 for some anatomy. But thanks everyone for tuning in.
Yeah, Eugene, I think Susie next had a question.
Yeah. Are there multiple types of folic acid? Would an antifolic drug affect hematopoiesis, since it also needs folic acid, or only DNA replication? I'm actually not too sure about this. I'll have to check that up. So I'll check that up right now, and then I'll reply in the chat. Okay. But good question though.
All right, David, for the next bit, do you want me to share screen?
Yeah, sure, go for it.
All
Because
right.
Susan, just with the reason why it's contraindicated in pregnant women is because folic acid is necessary for a lot of metabolism of a lot of cells. So it's really important for the growth of the fetus, and it can cause spina bifida if there's a lack of folic acid in the pregnant woman.
Yeah, so I think they even do like a test, right, to check the folic acid. for
Yeah,
one
but it's
kid.
a good question with hematopoiesis. I don't know either.
All right, guys, we're gonna whiz through this next bit. Pretty much the HKS this week is super short, and Pete and I were talking about the HEP, and I think it will just give you like the very brief highlights. So for access to healthcare, you just have these 4 learning objectives. Pretty much 1 and 2 are covered in the lectures, and 3 and 4 are then covered in your classes. I've touched on 3 a little bit on the last slide, but they're like pretty straightforward. So as you can see, the first learning objective there was about access and equity. And pretty much all they want you to know is the Tanahashi framework model. So this framework has like 5-ish areas. The first is availability, second is accessibility, third is acceptability, fourth is contact, and fifth is effectiveness. I've listed the definitions there, but just to go through them super briefly, availability is pretty much to whom the service is like available, like the service exists and who can like have access to that service hypothetically. But like problems include like if the service isn't there, then it's not available, right? Like if it doesn't exist, it's not available. Or like if the service is only open on like, I know, Saturdays 10 to 2 and you work 10 to 2, then it's not available to you either. The second thing is accessibility. So that's like technically the service is available, but then how do you like actually access it? So maybe you live like 10 kilometers away, not that far, but you don't have like any transport, so it's not accessible. Like you might be available, the service might be available, but you just can't access it because you're too far away because you can't get there. Or things like costs, if you have to pay, maybe you can't afford to pay, so that's accessibility. Thirdly is acceptability. So like in some cultures, maybe they don't like it when you go to that clinic, or for instance, if it's like a psychiatrist place, they like look down on mental health issues and go in there. So like it's available, it exists, it's accessible, like you can get there hypothetically, but it's just not acceptable to do it because your culture or social norms don't accept it. Number 4 is the contact coverage. And this just refers to the group of people who actually use the service. And number 5 is effectiveness. So let's say it's like a psychiatrist clinic, people use it, but if they only use it once and the psychiatrist is like, come back next week, and they don't come back, that means it's not effective because you haven't actually like followed through. Oftentimes with like medicine, you see a patient once and it's not enough. You need more time with them. So that's just the Tanahashi framework. And then the second bit of your HKS for this week was about health inequity and pretty much where it comes from. So it comes from 3 main areas. You have your structural factors, so your lack of facilities or geographic remoteness. Cultural factors, this goes back into the acceptability. And social factors like time and cost. Time is like dual here. It's like time taken to get to some place, but also time away from like your family or time away from work. So for instance, I know our neighbors, they like don't like to go to like the specialist because it takes too much time away from their parents and they have to spend time looking after their parents. And then that last third and fourth dot points were about which cohorts in Australia specifically are at risk of like having health inequalities. And that's pretty much if you're remote or regional, you're having problems with access. Indigenous Australians, so same thing, problems with access, but also the cultural side, so acceptability. Non-English speaking backgrounds, so if your service doesn't have like translators, like you can't access it, or like if you can't search it up on Google, you don't know where to find it. And then lastly, low socioeconomic, so if you can't pay. So for instance, with the psychiatry example, I think you get 10 sessions for free, and then after that you have to pay. And it's super expensive. So if you don't have the money, you're not going to be spending the money on pain. You're going to be spending the money on like your bills. So that is pretty much HKS done in a nutshell. And then the HEP, you have 2 lectures this week. You have one on nutrition, and the other one I think on exercise, I want to say. But Peter's doing the second one. So nutrition, honestly, is just super, 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 super low yield, like the lowest yield you can get. The only thing like really that you need to get out of this is that Craig loves the Mediterranean diet. So if there's like an exam question about the Mediterranean diet, assume it's good. So like what helps cure something? Mediterranean diet.
I'll catch it. There's a
Yeah.
question in the chat that's pretty good. It's
Oh,
asking what type of questions come up for HEP. What are
For
your
HEP?
opinions? Yeah.
okay. There are generally like 3-ish type of questions you can get. The first would be like the random fact. So sometimes they just want you to like have a random fact from the lectures that seemingly comes out of nowhere and you just have to know it. So one of the ones we had, or like on the practice exam, was about mindfulness. So they had like different facts and you choose like the right fact. And the question was something along the lines of like, for those who practice mindfulness at age 50, like how much younger is their brain? So like option A was like, 5 years younger. Option B was like 10 years younger. Anyway, the correct answer for that was 7.5 years. So it's like a random fact that comes across somewhere and you just have to know it. But we'll try to hone in on those facts that have like come across year after year after year. So that's number one. Number two is like what I like to call like common sense questions. So things like they'll ask questions like what contributes to cancer, or like what contributes to mental health problems, or what stops you from becoming ill. And the answer to something will be like exercise is good, mindfulness is good, having a good diet, Mediterranean diet is good. It's like more common sense. You don't really have to watch lectures to be able to answer those questions, whereas like the random facts you do. And then the third one would be something specifically you've studied, like a broader concept. So like earlier in the semester, we talked about the default, like the online brain and the default brain. So it's like a pretty broad concept. So they might ask questions about that, or questions about like stress, like what happens during stress. So it's not quite common sense. It's not quite a fact, but it's more like the larger concepts. So for here, for instance, a larger concept about nutrition would be something along the lines of that diet can severely affect illness progression. So a bad diet is really bad. And a good diet, conversely, can help cure some like chronic illnesses. But that's an excellent question. And thanks, David. Tell me if like other ones pop up in the chat. Here it's just telling you why learning about nutrition is important. These are like the first 14 slides summarized. Pretty much the stance is that nutrition has a huge like burden on the system. Like people who are overweight or don't eat enough, they are definitely more likely to get sick. So in total, when they like calculated it, it was around 255 million DALYs, which is the disability adjusted life years. So that's how many years like your life quality isn't like up to normal because of nutritional problems. There are a lot of diets out there. The ones we mainly like to focus on in med is the Mediterranean diet, which I go in later, like what that actually entails, and also the Western diet. So keep an eye out for those two, Western diet and Mediterranean diet. Generally, good things are like whole food, fresh food, plant-based food, few empty calories, so like not a lot of junk food. And Australia in general has a huge problem with obesity, that's on the rise, and junk food consumption, that's also on the rise, in case you need, and I get asked a question about like trends. So yeah, Mediterranean diet has a lot of veggies, except like your starchy veggies like potato, a lot of fruits, a lot of nuts, a lot of whole grains, that's like wholemeal bread, for instance, a lot of fish, a lot of those like good acids from the fish. Red and processed meats, keep an eye out for that because processed meat is generally considered bad, which is like the only drawback of the Mediterranean diet. And some alcohol, but like they don't like necessarily support alcohol. Conversely, the Western diet is what they like to think we eat right now. So it's like a lot more of processed meat, which is bad. A lot more butter, a lot more dairy, a lot more eggs, a lot more sweets, a lot more desserts. So pretty much what like the Western lifestyle is like, that's the Western diet. So Western diet is bad, Mediterranean diet is good. That's all you need to know. He touches a little bit on intermittent fasting and periodic fasting. Pretty much it's like you eat dinner at 8 p.m. and then you wait 16 hours until your next meal. So 16 hours would be like 12. So you eat at 8 and then the next day you eat at 12. The idea why this is good is that it helps your body like rebalance a little bit. And then it also helps the biggest thing with diabetes. So if you get a question about what helps diabetes, it's intermittent fasting or periodic fasting. Periodic fasting is like a little bit longer. It's instead of like 16-hour break, it's like a little bit longer, 2 days. Then in the slides, when I was going through them, you guys had like 15 slides on breast cancer. And it was like this, like veggies and breast cancer or fat and breast cancer. Pretty much I've summarized those into those 5 dot points. And it's pretty much what reduces breast cancer risk. Honestly, I think the one thing you'd be tested on here potentially is that veggies and fruits help reduce breast cancer risk. The other ones are sort of a little bit more niche. I'd be surprised that you got tested on that. And then later on, you also got slides on like different illnesses and what helps. So I've just summarized it in this table. Please feel free to go through it. The ones I would highlight is that for overweight, Craig loves saying that mindfulness helps. And then for binge eating, mindfulness helps as well. I think those would be the big ones. And Mediterranean diet is good for Parkinson's disease and cardiovascular disease and pretty much a lot of everything else. Meat can cause cancer, so it's a carcinogen. You could get a question on that. Particularly processed meats, so meat that's been like processed a couple of times, like sausages or salami, that's been processed a lot. And then there are meats we think cause cancer, but we can't like really prove it yet, but we think it does. So that's stuff like red meat in general and pork. But we haven't proven anything, but we think it causes cancer. And that's literally it. Peter, take over.
Yep, thank you. Also, just a note on the HEP exam. Last year, I think there was like 8 marks for Sem 1, and like the cohort median was like 6 or 7. And I can guarantee you, like most guys did not spend their time studying HEP. So generally, you don't get asked like 8 stat questions. That's kind of just, it's like a mixture of those 3. So don't stress too much. I think it's better to just know the general idea and see if you can find some stats that maybe Craig said is important, or maybe one of the PSB said is important, and just try to keep those in mind. No point memorizing every stat for HEP because not a lot, yeah. All right, next slide, please.
I just checked 2 things I've written in the chat. I'm not 100% sure about. Did he say that 65% of Australians use CAMs and 72% who use CAMs don't tell their practitioners? Because that was definitely important. 72% is definitely true. Yeah, that's true. And the other one is Katya, processed meat, is that a type 1 carcinogen?
Yes.
Yeah. So I think there's a question about bacon on our exam.
I think so.
Something along those lines, yeah.
One of those, yeah.
So bacon is a type 1 carcinogen.
Yep, okay, so we'll be talking about exercise. So firstly, what happens if you don't exercise? Well, there's a link of various disease and health conditions. These are the main ones, I think. First of all, that it accounts for 6% of disease burden in males and 8% in females, and contributes to about 8,000 deaths, that's per year. And 70% of Australians over age of 15 are classed as sedentary, and that is most likely linked, to the fact that we have a different lifestyle now. So it's not necessarily because of the fact that we have genetics or anything. It's just now it's inactive in general. And it also shows that being active and having a normal BMI or weight adds to roughly 7.2 years of life. So obviously a huge amount of more life you can live if you're just active and in the normal weight. Also, inactivity also increases 2-fold rise of CHD. Yep. And also, if you have moderate physical activity done, mortality of heart attack is halved. And also those who are more likely to be inactive are women, language other than English, lower social, economic, and education, and those with children under 5. Physical exercise is good because of the effects on these 5 things: metabolics, genetics, and the physiological effects, the immunological effects, and the neurological effects that it has. Also, there's basically 3 types of exercise that the lectures will go through. The first one's aerobic, and this is basically useful for every exercise, but too much is bad. And that's kind of like a general rule of thumb. Too much is bad. Resistance, it's useful for all diseases, especially osteoporosis and strengthening of those, except cancer and dementia. And balance is useful for some diseases, but not dementia. Weight. So obesity, we have over a 5% prevalence increase over the last 10 years due to inactivity. So no genetics, just pure lifestyle. And it's very bad. And it's pretty obvious that it's pretty bad because we've always heard about it. Yeah, and about weight loss and exercise. So exercise is not good for rapid weight loss. There's no way you can lose weight over a short amount of time by just doing exercise. But it's really good for maintaining the weight. And obviously you don't want to have a rapid weight loss over and over again. So, and that's mainly because of the fact that weight loss is due to negative energy expenditure of these 3 mechanisms. And if you're doing rapid weight loss, it's going to harm your body in the end. Yep, next slide. So how much is good? Because I said that doing too much is bad, kind of, right? So again, it will depend on the situation. Like, for example, if you're an elderly, obviously you do less exercise than someone who's like 18, right? Because you're just built different in a way. But in general, too much is bad, but too little is also bad. Roughly, they want 60 to 70% of your volume O2 max during exercise, and 3 to 7 times a week with 30 to 45 minutes per day. So this is what's recommended, and this is what they think is the best after numerous studies. Also, there's a really fun fact. It's called like the Grim Walker walk or something like that. Basically, elderlies who walk faster than 5 kilometers per hour over the age of like 70 or something, basically elderlies avoided death compared to those who walked slower than 5 kilometers per hour after years of follow-up. So you can see that definitely there's some link to exercise, but we don't know exactly why that is the case, but the stats show that. Also, runners who live 3 years longer than non-runners in general. And they say that peak is about 4 hours running a week. So if you run like 6 hours a week, you'll still have the same benefits as those who run 4 hours a week, kind of, because it normally just plateaus. Yep, and this is the last slide, barriers of why people might not exercise, especially with the increase of prevalence of obesity. There must be some reasons, and this is because of the lack of time, lack of motivation, and lack of money as well, because nowadays there's like gyms and stuff, but you got to pay money for that, right? And it's kind of hard for those who don't have money to actually get the exercise. Physical injuries and conditions limiting movement, like you just naturally might be able to do it. And convenience, this is really a big thing for a lot of modern new kids out there. They just don't think it's convenient to do exercise. And that's it. Now, I did not cover all of it. There's a lot of interesting facts out there with like linking exercise to telomere length and stuff like that. So I would recommend you to read the lectures. I mean, I personally don't think you need to watch the lecture. I really didn't watch too much of the lectures, but I definitely feel like you should read the lecture at least once, just go through the slides. But yeah, that's all. Good job, guys. That was a pretty long session today, but yeah.
So maybe we'll stop recording so we don't have to edit it so much.